Hi, dear audience. Once again, we have our plenary talk scheduled. And for this plenary talk, we invited Professor Eiko, who is an associate professor in clinical psychology at Leiden University, the Netherlands. And in his lecture, he will describe a novel approach to conceptualizing mental health problems as emergent properties that arise from complex dynamical biopsychosocial systems rather than as a clear-cut categories with simple causes. And so you can post questions next to the live stream, and if we will have time, we'll answer them live. If not, I will forward them to Professor Fried to answer them later on in written form. So Professor Fried, I'll invite you to share your screen and to begin with your plenary talk.
All right, I hope you can hear me okay and can see my slides okay.
Yeah.
Thanks for the introduction. I'll remove your beautiful photograph from my screen so I see my slides. Thanks everybody for being here today, especially a shout out to all the early career researchers out there. I know it's been a hard year for all of us. Thanks for making it to the conference, and thanks to the organizers. Before many of you leave, because you guys say, well, I work in neuroscience, mental disorders is not my kind of jam. I want to warn you before you leave, because the talk may be interesting to you after all. I'm going to talk about emergent properties today. I'm going to talk about nosology in general that I would hope apply to your field as well. What are species? What are emotions? What are infectious diseases? How can we classify and categorize them? And I will conclude with the notion of mental disorders as biopsychosocial systems. You can find my slides online. You can also find a new paper that we submitted just a few weeks ago on this topic online. And you can always reach out to me via email or on Twitter if there are any questions. And I'm looking forward to discussions after this symposium today, after this lecture. Brief slide on urgency. Many of you will be aware of this. Mental disorders are highly prevalent, highly debilitating. They're one of the primary causes of suicide in the world, and highly costly on a personal level, but also societal and economical level. Despite massive research investments over the last few decades, including genetic and neuroscience research, there has been disappointingly limited progress in understanding, predicting, and treating mental health disorders. And we can reach more people today than we could reach in the 80s. But the core treatments for most mental disorders, such as depression, are still the same. We do cognitive behavioral therapy and we give them antidepressants. The situation is so dire that the pharmaceutical industry has removed themselves largely from the development of psychiatric drugs, at least for common mental disorders. I think there are many barriers to progress and many reasons why we have been so slow. And I've written my favorite topics in the last decades that I've written about a lot are shaky measurement foundations. I don't think we measure mental health problems very well or very accurately, and a lack of strong theories, a lack of theoretical foundations. But today's focus is diagnostic literalism and reductionism as challenges to progress in mental health research. And I will conclude with complexity research. All right, first topic, diagnostic literalism, taking diagnostic categories for more than they are. A question I will return to many times during this talk is, what are diagnoses actually? What are diagnoses of major depression, PTSD, obsessive compulsive disorder, schizophrenia, and so forth? And are they different from infectious diseases, from measles versus syphilis versus other infectious diseases, for example, or from cancer versus HIV? Now, an easy answer is, well, diagnoses are the things that are listed in our holy books. As most of you will know, we have a holy book of psychiatry, the DSM, and the DSM clearly defines mental disorders, such as major depressive disorder. You need to have one of the two cardinal symptoms, sad mood and anhedonia. You need to have 5 out of 9 overall symptoms, And these problems need to be there for about 2 weeks at least, for the majority of the days. This gives the impression that mental health disorders are a bit like colors or boxes. There's a purple box that's called major depressive disorder. There's an orange box called PTSD. These are separate colors. They're very clearly distinguishable from each other. They have clear boundaries. They have sharp boundaries between each other, and so forth. But I'm not sure if this is the right way to think about mental health problems, and I'll try to convince you why. But to do this, we need to look at the history of nosology for a few minutes. And the questions I want to ask: why are there 2 cardinal symptoms and not 3? Why do we have 9 overall symptoms and not 10? And why do we say you need 14 days of problems and not 16 days to qualify for a diagnosis of major depression? If mental health disorders are like these colors, if they're clearly separable things in the world that we can discover, then there should be clear answers to these questions. If not, if there are no clear answers, it speaks to the possibility that these categories are constructed, that they're manufactured rather than discovered. All right, in the 1940s and 50s in my field, in psychiatry and clinical psychology, there was a strong domination of psychoanalytic theory and practice. On the right, you can see Freud, of course, to the degree that nearly every US department chair at some point was an outspoken proponent of psychoanalysis. Folks who followed this framework held very negative views about diagnoses. They thought that diagnoses are harmful to the patient. And therefore, if you would show the same patient to 2 clinicians, they would rarely agree what problem the person had. Inter-rater reliability was basically 0. Many people back then thought that's a problem, or a growing group of people thought that's a problem, and they wanted to introduce the medical model to psychiatry that most of you, of course, work with a focus on signs and symptoms rather than sort of underlying processes and psychoanalytic theories and so on. One big step towards this was the 1957 paper by Cassidy. So I will give the example of depression now, but the same developments hold for other mental disorders. So for depression, there was an important paper, 57, where Cassidy and colleagues said, well, there needs to be mood change and 6 out of 10 symptoms are required. And I will get back to Cassidy later, so keep this paper in mind. Because there was an interview later and somebody asked him, Cassidy, why 6 out of 10? The most influential paper in modern psychiatry was the Plenary criteria, of course, 1972, who took Cassidy's paper and modified it a little bit. It's unclear why they modified it. This was not justified, but now we have 5 out of 8 rather than 6 out of 10 symptoms for depression. There was a whole pathway of these papers that all relied on each other, going back to a 1950 paper all the way to the DSM-3, published in 1980. And the DSM-3, in contrast to the DSM-2, contained all these criteria, symptoms, and so forth, like this more objective approach following the medical model. And you can see that overall, from 1950 to 1980, very little has changed. And in 2013, the DSM-5 was published, with very, very minor changes. So we're pretty much still in 1950 when it comes to these symptoms, largely speaking. And the point I want to make here, and I'm curious if that is the case in your own research fields too, is that these diagnostic categories and thresholds were shaped predominantly by historical forces, not empirical evidence. Of course, they were informed by clinical wisdom, small studies, and so forth. But given that today we still use criteria that largely go back to a 1950 paper with 12 participants or 13 participants, it's obvious that there's some path dependence in there. For example, Feiner in 1972 took Cassidy's criteria as a baseline, but there were alternative frameworks with equal validity that he could have taken, but he didn't. Another example, Kraepelin, the founding father of psychiatric nosology, had a competitor, Wernicke. And Wernicke was more influential at his time, but died prematurely in a bicycle accident, which gave Kraepelin the prominence in history that he has today. And so a historian of this topic, Ken Kendler, concluded that one can plausibly argue that DSM-5 would look meaningfully different today if any of these things would have happened, and there are many more, of course. And this is agreed upon among historians of psychiatry. Now we go back to Cassidy. Remember the 1957 paper with the 6 out of 10 symptoms? He was asked in an interview why, and he said, well, it sounded about right. We didn't have much more to go on back then. We needed to do something, and I thought, 6 out of 10 is good enough. And that's fine. I'm not criticizing Cassidy here. You need to start somewhere with nosology, but we need to realize that some of our foundations are pretty shaky. They're based on the decision of a single person with very limited evidence. And the same holds for many other psychiatric disorders. Now, going back to the question what diagnoses are. In 1913, a famous psychiatrist, Jaspers, wrote, or I guess medical doctor back then wrote, "It is the main task of psychiatry to find the natural disease units which are distinct in principle and without overlap from each other and which have the same symptoms, course, cause, and physical abnormalities." Natural disease units. But arguably, we have been unable to find natural disease units. And if my path dependence arguments were not convincing, I'll show you a couple other arguments. Inter-rater reliability among clinicians for mental disorders is at best moderate and often low. In the largest study on the topic, the DSM-5 field trials, tens of thousands of patients, thousands of clinicians, inter-rater reliability for major depressive disorder was 0.28 on a scale from 0 to 1. So that's absolutely abysmal. There's massive disagreement regarding how to operationalize mental disorders. There are 280 different rating scales for depression. The common rating scales for depression encompass over 50 different symptoms. There's massive heterogeneity within each diagnostic category. There are over 10,000 ways to meet a DSM-5 diagnosis for major depression, meaning you can see 10,000 patients, none of which share the same symptom profile. And we're not even talking about etiology or biophysiology and so forth. There's comorbidity among diagnostic categories. 50% of people with major depression have at least one other mental disorder, and so forth and so forth. So on the right side, this idea with these separate colors in separate boxes is not justifiable, although that is how psychiatry today still works. So one idea here is to say, well, maybe there are different ways to do this that are all equally defensible. For example, there's the DSM, but we also have the ICD, which is also an official nosology that is used in Europe. Maybe these are all, or these can be in principle equally good, because none of them carve nature at our joints. These are all high-level descriptions of something much more complicated than what we make it out to be. And so at this point in my talk, I thought, Eiko, let's step back. Why don't we say what mental disorders are not? Why don't we get the easy things out of the way? And so here I'll propose, and at least in my area, this is not very contentious, that mental disorders are not natural kinds. So what's a natural kind? Natural kinds are categories in nature that we discover and don't construct. Natural kinds are unchanging and carve nature at her joints. They have sharp boundaries from each other, and every natural kind has a set of properties that are both necessary and sufficient for classification. I'll give you an example here. The table of elements is usually discussed as a prime example for natural kinds. Every element has an atomic number. Gold has 79, for example, which is the number of protons, and it uniquely defines an element. No matter if you're an alien species very far away, you will also discover the same table of elements if you have the scientific equipment and so forth in progress. Mental disorders are not like elements, I think. But now it's important to acknowledge that many other things are neither natural kinds. biological species, for example. For the longest time, thousands of years, humans thought biological species are natural kinds. We can discover them in nature. But of course, we know after Darwin that biological species change over time. They evolve, they merge, they split up. Heterogeneity among the genome of a species is what makes a species a species. You can't have a species if every beaver has exactly the same genome. Terrible things will happen, right? So nosology is hard, and we're not the only ones who failed our mission to discover disease units in nature. So does it mean we give up on biological nosology or psychiatric nosology? No, it doesn't mean we need to give up. It means we need to find a middle ground between the idea that mental disorders can be discovered in nature on the one hand, and on the other, that they're just purely socially made up. And there is a reasonable middle ground. I'm going to give you some examples. Long-term high blood pressure is real. Nobody would say it's socially constructed. There is such a thing as blood pressure that is high. And it's important because it predicts mortality and morbidity and comorbidities and so forth. But the boundary of low to high blood pressure is arbitrary, or at least somewhat arbitrary. There is no clear category in nature. We need to make that up. We manufacture that threshold, and that's okay. Statistics helps with this. Socioeconomic status. Income is real. Neighborhood is real. Where people live is real. Poverty is real. But calculating socioeconomic status is contentious. There are many, many ways to do this. There are many variables that could go into this number. And in that sense, it is a manufactured number. Emotions. When I studied psychology, I had a class on emotions, and I was taught all the frameworks. There are 5 basic emotions. There are 7 basic emotions. There are 10 basic emotions. There are 16 basic emotions, and you see where it goes from there. The world isn't that simple. People claiming there are 5 basic emotions, in my view, summarize a much more complex system in 5 components. That's fine. It is manufactured, the idea of 5, but it is no less true or real, right? And so I think that's important. I'm not saying that mental disorders don't exist or they shouldn't be treated. I'm saying that the current categorization is arbitrary to some degree and probably will remain arbitrary in the future to some degree. And I'll try to convince you why that is. And so the first obstacle I identified today, diagnostic literalism, is taking diagnostic categories for more than they are, impeding progress. We can take a case control study for depression. Let's take neuroimaging here. So we compare the brain structures of people with depression and without depression. In my view, this has limited, this is important, we should do this, but there's limited information we can gain from this because depression is not like helium or magnesium. Depression is to some degree arbitrarily constructed. And that limits the usefulness of case control studies in psychiatric disorders, in my view. And that's why I think that in the scientific literature, we need to be a little bit more careful when we talk about genes for depression, risk factors for GAD, the best treatment for schizophrenia, because we're reifying rough clinical proxies, and we give patients and other people, the community, the idea that these are natural kinds in the universe. And I'm looking forward to feedback and thoughts and criticism on this perspective. Now, the second perspective is a bit more dangerous, given that this is a strongly biologically oriented medical conference, but I'm going to try to convince you anyway that we have been working too oversimplistically in my area and also in your area when it comes to mental health research. But before I do this, I need to highlight, actually, before I do this, let me look at the clock. Okay, we're good. Before I do this, I want to highlight that reductionism is super awesome. The idea that we can decompose a system to its elements and their relations, and then try to figure out what's wrong and try to repair the system is one of the most fundamental insights in science ever. Right? So if I have a bicycle, it has a cog and a wheel and a pedal, and I can understand the properties of the bicycle by understanding the properties of its elements. Awesome. very important. But when we try to interrogate complex systems like the weather, the stock market, the internet, or mental health problems, reductionism as a tool has limited utility. And the more complex the system, the more limited the utility. And I'm going to give you some examples today. I also want to stress that there's brilliant work on complexity in my area, of course. So I'm not calling out these people. I'm also not saying there is no proper work in my area. I'm saying that 98% of the work we do, including my own work, has been overly reductionistic and overly simplistic, and I think we ought to do better. Now, reductionism comes in many forms. Another short disclaimer, and I think it impedes progress. There are many types of reductionism. For example, Freud's or the Freudians focus on the unconscious that has dominated my field for way too long. But today, as an example, I will use biological reductionism because it is the current framework that dominates my research area, psychiatry and clinical psychology. The idea that we can find the biological root of all mental health disorders and that this will ultimately lead to treatments for everyone. And to define this properly, in philosophy of science, reductionism is the idea that a system like my bicycle can be reduced to its elements, in the sense that the bicycle is nothing more than these elements. So the total is just the sum of the parts, basically. And biological reductionism is the idea that mental disorders can be reduced to biology in the sense that they are nothing more than biology. The conclusion is then understanding biology is sufficient for understanding mental health problems in full. Now, this argument is difficult to make because obviously I need examples for this. And I decided as examples, I will use the largest, most well-funded, most powerful people in this research area because they can probably take some criticism. So I'm not singling out any smaller research group here. And so the first example out of two is the National Institute of Mental Health. The National Institute of Mental Health in the US, super powerful organization with massive funding infrastructure, has had 4 or 5 directors in the last 2 decades who were all very, very focused on understanding the biology of mental health disorders. So there were multiple directives in the last decade. I'm quoting from them now, where they defined mental health disorders as brain disorders, brain circuit disorders, and dysfunctions of neural circuits that can be identified with tools of clinical neuroscience and treated by tuning these neural circuits, ultimately leading to neuroscience-based psychiatric classification. Not sure if you see any issues there. My problem here is that obviously we need to study brains of people with mental health problems, and obviously many of the issues people have in their lives will be reflected to some degree in the brain. That's how the brain works. But moving nosology, diagnosis, dysfunction, and treatment all only to the level of the brain ignores so many problems that people are faced with every day. Depressed patients that I see are poor. They cannot afford healthcare. They cannot treat medical conditions and are therefore depressed. Some of them are stuck in abusive relationships that they can't get out of. Others have drug problems that they struggle with and then develop depression as a consequence. Focusing solely on the brain does not do these people justice, in my opinion. There's much more at stake here than just the brain. Another example, there's a 2017 paper, again, it's a mega-analysis with 100 authors where they compared ADHD, people with ADHD and a control group with people without ADHD, several thousand people in both groups. And they looked at structural brain differences, and they found a few very, very small structural differences. And they concluded that patients with ADHD have altered brains. Therefore, ADHD is a disorder of the brain. And I really struggled with this conclusion because we also know that people with ADHD have a different personality structure. Like if I take 5,000 people with and without, and I correlate it to neuroticism or extraversion, I find significant differences, much stronger than the differences of brain structures here. But nobody in their right mind would conclude that therefore, so patients with ADHD have altered personality, therefore ADHD is a disorder of the personality. That just doesn't follow. I don't think this works out. All right. So who is responsible for biological reductionism? Well, to some degree, a field that we call biological psychiatry, that's very well funded. And I want to say here that biological psychiatry has led to massive insights into how genes and brains work. I think that's super important to acknowledge. But the field has done very little to tell us about the biology of specific mental disorders, in part because maybe the categorization we currently have isn't the right categorization to look into. So I can probably skip this slide. There are many problems in this area of research, as there are in many other areas of research. I think I'll skip this slide and move forward. Even Thomas Insel, Professor Thomas Insel, NIMH director for many years, who I took his photograph here from Wikipedia, and it might not be an accident that his Wikipedia photograph has Principles of Neuroscience, his book under his arm here. He said in an interview not long ago, after 13 years of really pushing on the neuroscience and genetics of mental disorders, I succeeded at got some cool papers published at costs of about $20 billion. But I don't think we moved the needle in reducing suicide, reducing hospitalizations, improving recovery for tens of millions of people who have mental illness. So lots of cool discoveries, but really nothing that is clinically applicable. And we've done this for 32 years now, I think. Biological psychiatry came up end of the 80s, beginning of the 90s. And there have been some insights for rare fringe disorders, but for major depression, generalized anxiety disorder, schizophrenia, and so forth, we really don't do much differently than 30 years ago, 20 years ago. And if you want to read a scathing critique of biological psychiatry that I do not fully agree with, but I think it's an interesting piece, I can recommend the recent paper by Andrew Scull, published in Psychological Medicine. Okay, conclusion of these two big problems, and then we move forward. I think there is strong evidence at this point that mental disorders are complex systems, and that reductionist approaches, no matter if biological or psychological or social or whatnot, have limited utility for such systems. In addition, I think that reductionist approaches have focused on the wrong targets. Biological psychiatry has tried to understand the genes of major depression or the brains of schizophrenia, but I don't think these are clear-cut categories in nature. I think they might be the wrong targets, and there are other initiatives on the way, like RDoC or HITOP, that may be more promising, which focus on targeting mechanisms, for example, rather than these big categories. All right. 15 minutes left. In addition, these two barriers to progress have reinforced each other. I think diagnostic literalism and reductionism have formed a vicious cycle of reification. We end up with some path dependence in a category, in a psychiatric disorder category. We correlate brain correlates to this category. We find that the amygdala is a little bit more active or a little bit larger. The hippocampus is a little smaller in this category. And then we say, oh, well, this category is real, therefore, and then we continue from there. But that's not warranted, of course. All right. I live in the Netherlands. You guys know we all cycle a lot, so my moving forward slide is also about bicycles. 2 years ago, I was in Virginia and Richmond, and I had the huge privilege to work with my scientific hero, Kenneth Kendler, a psychiatrist who I've always looked up to very, very much. And he was kind enough to lend me his second bicycle. Vintage, super old, very expensive, I think. And he said I could take good care of it. And it took a few weeks until the bicycle broke. And I was super nervous, but luckily reductionism works, I could easily identify the right part of the bicycle that was broken. I could repair it and fix it because I can understand the bicycle as a whole from the sum of its elements. So that worked out really well. But the core point of my paper and my talk today is that mental disorders are not like bicycles. And I wonder to the degree to which medical disorders that you guys are working on are like bicycles. Mental disorders arise within a person over time and are best understood as phenomena resulting from interactions of biopsychosocial elements organized in hierarchies of interdependent levels. That's a mouthful, but it's complicated, I think, is the summary of that sentence. And the coolest thing is, and over the last 2 years, I've been working with network models, graph theory. Networks on the right side are a way where we can analyze and try to depict these complicated hierarchies to some degree, at least. Now, the cool thing is, so some people say, Eiko, everything's so complicated. That's a downer. I don't know what to do now. That's super disheartening. Can we ever learn anything? But I think the greatest strength of this view is that we can stop our simplistic interrogation of mental health disorders, and we can use rich theories and rich methods from a long tradition of complexity science that has many adjacent fields like network sciences and system sciences. And these theories and methods have shown to be generic to some degree. Many complex systems exhibit features that are the same, no matter if ecology, biology, the weather forecasting, the stock market, all of these systems have similar features. They have early warning systems, they have phase transitions and so forth. And I want to talk about this just a little bit today. All right. So I hope you can see this video here. I usually regret showing this video because people stop listening to my voice when I show it, but I'm going to risk it anyway. You know what that is, of course. This is bird flocking behavior, and this is a pattern we call emergence. Something emerges from this flock of birds, and I recommend the Wikipedia on this. Actually, for the longest time, scientists thought that there's a sort of a captain general bird that tells all the other birds where to fly, but that's not the case, of course. None of the birds causes flocking behavior. None of the birds is responsible for this. All the birds do is they interact with their direct neighbors. There are 8 direct neighbors, and then you get this sort of swarm behavior that you also see in fish. So I can fully understand my bicycle, the macro behavior of my bicycle from the micro level. But in emergent systems, this is not the case. I cannot understand the macro behavior of birds from an individual bird. Further, the macro behavior is present in the group, but it is absent in its elements. So we talked about flocking behavior. A bird does not flock, many birds flock. Hydrogen or oxygen are not wet or fluid, they're elements. But if you put them together and you take a lot of it, you get an emergent property of fluidity. Predators develop in certain populations over time. But if you add prey populations to the system, you get an emergent behavior of sort of a sine wave that goes up and down. The more predators, the fewer prey, the fewer prey, the fewer predators, because there's not enough food anymore. Then the prey grow again, and then the predators grow because there's enough food and so forth. Now, the coolest thing that I've learned in the last few years is that emergent properties have independent causal status. And I really recommend the book by Sandra Mitchell on the topic. The example is from her book here. So bees collect honey, as you know, and you can study the genes and the neural structure of a bee all you want. You will never understand how they collectively agree to collect honey, whose responsibility these things are, and so forth. You need to study the social system among bees to understand that. And even more remarkable, once the beehive is full, once the honey is sort of at the, once the honey jar is full, the full honey jar exhibits causal effects on each individual bee to stop collecting honey. But of course, the honey jar is not part of the bee itself. It's only part of the swarm of bees. I find that fascinating to think about what that means for mental health disorders. Another topic that is really important in complex systems are early warning signals. And I'm going to show you how we can utilize this for mental health disorders. So systems like lakes or depressed patients or the weather can have multiple stable states. And we show this with resilience landscapes. So all you need to know there is that these are mountains and they follow gravity. Now our person or our lake is the billiard ball, the black billiard ball. And on the left side, you can see, adverse life events, stressors, pollution are perturbations to this billiard ball. So I push the ball to the left and I push the ball to the right, and it will rest down again in this cubby hole. And strong perturbations are stronger push. That's the metaphor here. On the left side, you can see it would take a lot of force to move the person or the lake to the other state, to the disease state. But you can also see it would be much harder to then move the person back to the healthy state. So that's a bistable system. On the right side, you can see that it would take only a little push to move the person into a disease state like depression. So that's a low resilience system. And now the coolest thing is I can simply by looking at a person or lake over time tell you if they are resilient or not. But I need this complex systems angle to be able to do this. How does it work? You can ignore the complicated graphs here. I'm going to just explain this. If I perturb the left system and the right system a little bit, if I push them with the same force to the left side, the left system will come to rest much quicker than the right system. The right system will go left, right, left, right, left, right, and then stop. And that means that the variance and the autocorrelation is different in the right system than the left system. And that means I can look at a patient who is healthy, maybe somebody with a past history of major depression. I can follow this person over time, and I will see that close to a tipping point, their variances and autocorrelations will go up before they transition to a new state. And that's, I think, the most remarkable insight for mental health research we can have right now. It offers such amazing possibilities. And in the sake of time, I will skip the next slide. There's a paper by Marieke Wichers, 2016, in the Netherlands, in Groningen, who has shown that this is actually the case, that you can forecast a transition into depression by changing in early warning signals. This is in one person, so we certainly need to do this and replicate this out of sample in many more people. But I find this extremely promising. And again, I wonder, going back to the conference here, how this could be applied to your kind of work. If this is done already in some of your work, upcoming seizures or upcoming cardiac arrest or other problems. So be curious. So going back to my core question, what are diagnoses? From a systems perspective, the answer changes. Diagnoses are simplifying useful heuristic tools with the goal to understand the world. They're not ontological convictions. They're not something we learn in med school and then we stick with them. They're descriptions, they're simplifications. I don't think they're true. That doesn't mean mental health doesn't exist. Again, there's an important middle ground here. The system perspective changes monocausal thinking about mental health research, which we have seen too much. Systems perspective that embraces the complexity of these problems calls into question the privileged epistemological status of symptoms over other constructs. Remember, in the DSM, if you want to be able to diagnose somebody, there's just a list of symptoms. But what about etiology? What about underlying processes? What about social systems? What about support? Social support is a strong predictor for not becoming depressed under adversity. How is that not relevant to the system from a diagnostic perspective? There are also biological markers. We know that together, I think all the genes we've identified for depression predict about 4, 5, 6% of the variance. That's enough to add it to an important multi-causal model, of course, that will help us with prediction. And the systems perspective also aligns with how clinicians think and treat mental health problems, at least in clinical psychology, where the idea of vicious cycles is very, very well established, of course. You treat cognitions to avoid negative emotions and so forth. It's core to cognitive behavioral therapy. All right. Next steps are obvious. We need to study mental health disorders as holistic systems. As we say in a recent paper, it's systems all the way down. And this means we need not only study the system of mental health, it also intersects with other systems. The healthcare system, which determines if people can get treatment. The political system, which determines the amount of stigma people may receive, for example. The education system, which allows people to seek the education they want, and so on and so on. Second, and again, maybe in your areas, people are doing this better than in my field, clinical psychology, but in my area, most of our theories are just verbal. They're narrative stories. We don't have proper formal computational models, but that's crucial when you try to understand complex systems, because they behave in very non-intuitive ways. Even minimal changes to input into a system can radically change the macro behavior of a system. Skip this. Okay, my last few slides. 2 days ago, we went live with the recruitment for a new large study. And I want to talk to you briefly about the study, because this is my way of trying to embrace the complexity of mental health disorders, and I hope it'll be insightful to some degree. So what we're doing is we're trying to develop an early warning system for depression. To do so, we will follow 2,000 students in the Netherlands over 2 years. There's a thorough 2,000 healthy students, so they can have some normal mental health problems, but they're not supposed to be depressed. We collect a large baseline battery of data and 2,000 people at baseline. Then we follow people over time using smartphone questions every day. We will ask them 3 or 4 times a day, just a few brief questions. How did you sleep? Are you sad right now? We're trying to interrogate their system, basically, social contacts, life stressors, and so on. They will also get a smartwatch from us for 3 months, where we get actigraphy, heart rate, stress, sleep, and so forth, so a bit more objective data. And then we will follow them every couple of weeks or months and ask them, basically, are you depressed right now, is the idea here. So we're trying to find out whether they transition into depression. And then we will use theory-driven work and machine learning data-driven work to see if we can predict with these dynamic data in stage 2 better than just from baseline data, whether people transition into depression and when. And the idea here is then to build an early warning system for depression. There's 2 people here. The first person is doing well in life. All the smartphone and smartwatch information tells us everything is fine. This is likely going to be an app we develop on the smartphone. And in the second case here, you can see that this person transitions into depression, or would transition into depression based on our model. And we can assign this person a high-risk group based on our prediction models before depression occurs, and start with personalized intervention at the right time. Now, we just started. This is a 5-year project. I'm curious how far we will get, but this is sort of my best try to make an impact here using complex systems theories. I'd like to thank the organizers of the conference for inviting me. It's very kind of you, Rob Goldston, who invited the paper on the topic and convinced me to work on this. Ken Kendler, who has been super insightful on these topics and discussions over the years. And of course, the European Union for funding me and my research. Thank you so much. Slides and paper again. And I'm very, very genuinely looking forward to questions, feedback, criticism, and so on. Curious what you guys think.
So thank you, Professor Fritz, for this interesting and thought-provoking lesson or presentation. We have a short amount of time to tackle, maybe just one question, and then I can forward the rest of them to you later on. So you were mentioning diagnosis as a problem, but one question came, and do you think that the diagnosis is not just a good thing for the clinicians, but also for the patient, because they find finally a label that can assign their problems to?
Yeah, so in the US, there has been a huge move towards labels and diagnosis in the 80s and 90s, because we assumed that it would help all patients to get a label. I finally know what I have. And we know from research, especially in the last 10 or 15 years, that it can help indeed some people a lot who are looking for something, a label, a category. Oh, I'm just, I have this problem here. It's not me, it's this disorder. And that's true. It should work like this. But for many people, it's also a burden. So this idea of assigning a label works for some people, and it really doesn't for others. And so, yeah, we need to work together with the community and the clinicians to figure out how we can personalize this idea a little bit more than we currently do it. That's a great question. Thank you.
And will you use the same labeling system as traditional in your study as well to define depression?
It's such a tricky question, Mate. Yeah, excellent point, right? So how do we define depression in my study? I needed to get the study funded, and early warning system for stress and anxiety and depression-related behaviors was too long. But yes, what we will do is we will predict our dependent variable will be something like mood disorders and anxiety disorders and severe increases in stress and impairment at the same time. And we will train our models to predict all these 4 components at the same time to see which predictors generalize. And I'm a transdiagnostic guy. I think our predictors will do pretty well for all these 4 different variables because they tend to go together a lot. But yeah, you nailed it. That's a perfect question.
I mean, the project sounds really great, and a different kind of approach as one would usually expect. Then I don't want to cut in the break time too much, so I think we can end with the discussion here. I'd like to thank you once again for the presentation, and we'll forward you a couple of questions that came via the chat, so you can answer them, and then we will forward them to our audience in the extended Q&A session.
Thanks so much.